This is a special session, and all of the work that we are doing is focused on the patients who are being treated, and at this time we have an opportunity to hear their voices. And so to run this session, what I'd like to do is initially ask the panelists to introduce themselves, say where they're from, and say which patient group they represent. And then after that, each of the panelists will have 5 minutes to talk about the pressing concerns and issues that their patient group has voiced to them, so that we as an audience can understand that, and the person who will lead off on that will be Lynn. So maybe we can start with you to introduce yourself.
Sure. Hello? This one? Okay. Hi. I'm Gary Robinson. I'm from Glasgow in Scotland, and I'm an IgA nephropathy patient.
Okay. Fabrizio Spoletti from Italy. I'm a father of a patient with DDD, and I deal with this illness since 17 years. And 12 years ago, I founded the Patient Association for C3G in Italy.
Excuse me. I'm Lynn Lanning from Iowa City, Iowa, and I am a mother of Jenna, who has C3G. She's an identical twin, and her twin sister has type 1 diabetes, which was interesting listening to your conversation today. Richard and I founded Kidneys and back in 1997 to try to find a treatment for Jenna, and we ambitiously hope to be able to treat the disease. It's really exciting to see where it is here today.
Hello, my name is Marianne Silkjær Nielsen. I'm the mother of a girl with IC-MPGN. I'm also the founder of an association called ComCure, and I'm really delighted to be here and to meet all of you.
Good morning. I'm Alistair Humphreys from the UK, and I'm an IgA nephropathy patient.
Hi, my name is Lauren Fisher. I'm from Denver, Colorado, and I am an FSGS patient.
Hello, my name's Len Woodward. I'm from the UK. I'm not a patient, but I'm a patient advocate, and I've been for over 11 years now. And I'm an advocate on behalf of AHUS patients around the world.
Hello, I'm Marco Zuccato from Northern Italy, and I'm a patient affected by AAV. But I'm also a professor of history of science and medicine at the American University of Sharjah in the AAU. Thanks.
Thank you. So now we'll start with Lynn, and I'm going to, when you're close to 5 minutes up, I'll just tell you so that you can wrap it up so that everybody has an opportunity to speak.
Okay, in preparation for the panel, they gave us four questions to address with our patient population. And because there are 3 of us here with patient groups in C3G, we split that up. So I'm going to be answering the question that says, what aspect of your disease has the greatest impact on quality of life? In getting the results back, it broke into 3 different categories. One was the patients that have their native kidneys, pre-dialysis, pre-transplant, the patients that are on dialysis, or the patients that have a transplant. So for the pre-native kidney ones, pre-dialysis, pre-transplant, fear of disease recurrence was very high. The next area was mental health issues. And some of the comments I will read directly, others I'm just putting together. Fear of dying, fear of not being normal, a sense of not being normal. One young man wrote back that what he realizes now is he was going through the grief of losing the future that he thought he was going to have and coming to terms with that. Another one said that it affected the relationships between her and her siblings and her parents. A lot of fear and anger was directed to them, which was quite destructive of relationships. Earlier recognition of mental health issues on a diagnosis, especially from one teen who said that he felt that if he had had more, his caregiver had provided and talked and normalized the fear and anxiety they were going through, that he would not have had to miss so much school. He feels in retrospect the nausea, the physical symptoms that he was experiencing, a lot of them were simply reactive to stress and anxiety. There was another person who said that because of the same issue, they missed a lot of schooling, and that has limited their economic choices in the future and their career choices. Vision impairment, C3G patients have drusen, and vision was another issue that they dealt with. Another one was appearance, that the medications and treatments often cause swelling and bloodshot eyes, and as children and young adults, that can be particularly devastating. One person wrote that how I look and in turn how I feel about myself are very important. I need to look good in order to live the life that I want, and if I can't love the skin I live in, I don't want to be around people, and I'm very frustrated. Another talked about being bullied because of their appearance. Diet, the very restrictive diet that they have to live with. Somebody wrote, we need creative nutritionists, and we need our nutritionists to eat the same diet they're prescribing for us. Pregnancy and relationships were a big one, and that was in all three categories. That concern and the decisions. Some of the people had been told to have abortions because that would damage their kidneys, and other ones just wish that they had had more very close monitoring of their pregnancies so they wouldn't have lost function as well. Time out of the day was very important because they were missing a lot due to the hospital visits, from not feeling well. And one person wrote, quality of life would be very important if you had very good medical care providers, that it makes a huge difference to them. They can shape the way that they deal with the patients so that they are not patients, but they are. I'm getting close? Yeah. Okay. But know that you make a huge difference for better, for worse on that. The primary one on dialysis was those that are who have fistulas, and the appearance of fistulas, and also the anxiety around the integrity of their fistulas. Travel is hard, and space is hard. And I'll just give me one last one. One of their wish lists was to have a mobile app that could be used for their health care, putting in different clinical trials and information like that where they could easily access it.
Thanks,
And I
Lynn.
will stop.
Marianne?
Okay, so thank you. I was asked to talk about the unmet needs in our diseases. And in preparation of this, I have been in close contact with the German patient organization. I'm Danish, but I live in Switzerland, and I have a close bond with that association in particular. And the first undisputed need is a therapy. I think it's nice to see all of these candidates that are in development. That gives us hope, but right now we don't have any therapy. And that's devastating. Also looking at the outcome. And here we need to look not only at the outcome tomorrow, but at the long-term outcome. What kind of lives will our kids get? So that brings me to the next topic, and that is guidelines. It's very difficult to treat these diseases, and a lot of the publications are based on pretty small cohorts of patients. So I think in clinical practice, in reality, there is a lot of trial and error going on. And I can just share my own story with my daughter. I thought it was a unique story when we went through it, but connecting with a lot of other patients and caregivers, I realized that it's not a unique story. So she got sick in 2019. She was treated with steroids, high doses of steroids, and MMF. It did not help at all. Then, a few weeks later, we were still in hospital. She was treated with steroids again. It didn't help. A few weeks later again, she was treated with steroids. And guess what? It didn't help. But she got a stroke. She had sepsis. She was in coma. Very difficult. So I think, and then she was started on nicolizumab, and that was after 2 weeks. And a week later, I could send her back to school. So I think it would be great if we could have guidelines that are specifically helping clinicians to make the right choices and not to keep doing the same things and expecting a different outcome. My last point regards diagnosis. It's very difficult to diagnose these diseases. My daughter got sick in Denmark. I come from Denmark. And it was just, I think we had a lot of different diagnoses on the table. We tried a lot of different therapies. You know, it didn't really help. I mean, she just got sicker and sicker. She gained 60% weight because of edema. It was really not easy, and I think they reached out to a number of experts. They did both in Denmark and in Switzerland, and you know, we got a lot of different answers back. Actually, every expert gave a different answer back. So that's another challenge. And I think in order to solve the problem, getting us therapies, getting us access to therapies, you know, getting the diagnosis and the awareness, we need to create evidence. And based on this, I founded ComCure. I think we all need to share our data. We need to come together. We need to collaborate. We need to get as many patients into these registries as possible to create the evidence that we need in order to create the guidelines and make informed decisions. And some of them are clinical decisions, other decisions are health economic decisions. I think we need not only to look at what does the therapy cost, we also need to look at what value are they actually bringing. And in the hospital where my daughter is treated, I'm the only mother who works 100%. If you have a kid who is seriously sick, it's very difficult to have a productive life. My wish for my daughter is that she will be able to contribute to the welfare of society when she grows up and not be dependent on it. So please, when you assess this, don't just look at 2, 3, 10 years ahead. Look at the lifetime of these patients. Thank you.
Thank you very much. Alistair?
I guess there are similar stories that a lot of us have, either as patients or as caregivers. So I'm not going to take time going through my own individual story in that sense, because of the similarities in it. But one of the things that does strike me, and which I find very encouraging, is the fact that there is so much great work going into trying to bring therapies forward, and I'm talking specifically about IgA nephropathy. The point that has become apparent to me and others that I've spoken to with the disease is that not very many of us as patients are aware of the great work that is happening. So the one single point that I'm keen to leave in what I'm saying is there's got to be an approach taken which allows many, many more patients the opportunity to go onto a trial. Again, in the small number of patients that I've spoken to that are on a trial, mainly their reasons for participating are the fact that it gives hope. And given a lot of the backstories tend to be there is no hope, dialysis is inevitable, there's nothing that can be done. And actually the reality is there's so much that's being done, but the unmet need, or the gap, if you like, is the fact that patients aren't aware. I do think there's some of that is incumbent upon us as patients and as patient organisations to work with the relevant organisations, and I'm including pharma in that, to try and drive the education. So as well as the great work, which I obviously compliment everyone here on, actually what can we do to get that word out to the wider patient groups and to the patients themselves, so that they will ask their nephrologist, can I participate?
Thank you. Lauren?
Is it on? Okay. Just a little bit of background information on me. I've had FSGS for about 15 years. It's been kind of a slow progression disease for me. Currently at stage 3B, so I haven't had the experience of going through transplant or dialysis, and so my experience is really coming from that perspective. The questions that we were posed, the first one is, what are the unmet clinical needs of your disease? So for FSGS, understanding basic causes and drivers of that disease. I know we've talked this morning that this is a pretty diverse kind of condition, but particularly in cases of primary FSGS, and also for the number of patients who have relapse post-transplant, kind of understanding the pathways there and how do we prevent that from happening. I would say earlier diagnosis as well. It's probably not unique to FSGS. I was diagnosed being worked up for a separate condition, and I probably wouldn't know even to this day that I had FSGS because I've been fairly asymptomatic. And then, of course, the big one is treatment. Very encouraging now. I had a conversation with my nephrologist just this year about SGLT2 inhibitors, and so that's very promising. But again, it would be nice to have more treatment options available for patients to slow or stop the progression of this disease. The second question is, what aspect of this disease has the greatest impact on quality of life? For me, in my experience, this has been a chronic disease, and for me, really the big one is life planning. So this disease has impacted the level of education I've decided to pursue. It's currently something that I'm thinking about with family planning. I know we've mentioned that already in the patient panel. So thinking about if that's something that I'm going to be able to pursue. And then also making decisions about where I choose to live. I know as I get closer to needing dialysis or a transplant, you have to be close to a medical center in order to receive therapy. And speaking to a lot of complement inhibition therapy, which tends to be infusion-based therapy, those patients need to live close to facilities where they can access that care. The third question is, what aspect of treatment requires the most improvement? I would say for FSGS, I think there's a lot of room for improvement. Like we've talked about, though, there has been some improvement, and that's very encouraging. And finally, how do we improve clinical trial design? I am actually a clinical research nurse. I work in obstetrics, so a slightly different field. But kind of from my experience as an FSGS patient and also my experience as a clinical research nurse, I would say really trying to encourage broad participation. So are clinicians discussing these trials with their patients? Are patients educated on the options that they have? I am very lucky in that I do have a clinical research background, and I actively look for research opportunities, but not all patients are aware of those opportunities. And then the other one that affects me kind of personally is also I'm not eligible for a lot of trials at my institution based on age requirements and also renal function limits. So I am too young to participate in several studies at my institution where guidelines are 35 years up to participate, and also renal function. So my renal function is too far below certain inclusion requirements for certain trials. And so maybe something to think about in clinical trial design. And then finally, about improving clinical trial design, just reducing the invasiveness or burden on participants. Just from my experience as a clinical research nurse, that tends to encourage participants to participate in these trials.
Thank you, Lauren. Len?
Over the past 7 years, the Global Alliance has been gathering and maintaining a list of questions which patients regard as most matters to them. So I'll try and cover a selection of those questions. There are probably about 15 to 20 questions that are on our agenda. So starting with the genetics, people frequently ask, in my family there are people with AHUS. Why haven't I got AHUS? And that's a concern. And if I knew about my genetic predisposition, how does it help me? And they don't really understand the genetic reports that their clinicians share with them. Increasingly, because in recent years, AHUS is no longer an orphan disease by the definition of orphan disease. We have treatments, and we have more treatments potentially. So the key issue is accessing those treatments, the affordability of those treatments. And that's the question that patients ask. Why aren't, because less than 50% of patients are actually can access treatment. So and maybe the younger patients say, why can't it be made more affordable for more people around the world? One other question that's quite a consistent one is, will there be a genetic cure one day for AHUS? Is the technology there and could it be used? Another one that's sort of become much more popular in recent years, mainly because people are withdrawing from treatment, is how long can a remission last? Can it be predicted how long my remission will last if I have no treatment? And coupled with that is, why can some people come off treatment and other people can't? And that's something that needs clarity for them. It's less so now because there's much more information in recent years, but is there sufficient information to help parents make family planning decisions where one or other of the parents has AHUS? And I'll finish with another question that is important, which is the diagnosis of AHUS. 4 in 5 AHUS patients tell us that they enter clinical care in an urgent medical emergency, and just over 50% of them going into intensive care. From our research, from a survey that we've done in the last year or so of patients, less than 50% of patients presenting are diagnosed rapidly enough, and we define rapidly enough within 7 working days. Mostly it's because they've been misdiagnosed. For 30% of patients, that misdiagnosis goes way beyond even 30 working days, and for some it goes on for years. For some, the average length of time it takes to get a diagnosis is still 6 years, and that's because they've been misdiagnosed primarily with TTP, and there's some problem with that decision making. The misdiagnosis is the significant contributor to the worse health and treatment burden outcomes, according to our survey. So certainly an inclusive diagnosis process for AHUS is needed, but not one that leaves people still included with TTP patients, where the treatment there is even going to be less effective for AHUS patients in the acute stage with the caplacizumab. If that's what the first line treatment is, it's not going to help AS patients, like plasma exchange, could have helped them if only temporarily.
Thank you very much, Len. Marco?
Yep. So I'll be kind of brief. I want to see the things also from a more theoretical point of view. Of course, I represent the patients affected with AAV and associated ankle vasculitis. And we know that this is a serious illness that is active over a long period of time. And we have, I think, a very, at the moment, a very powerful drug, avacopan, the star, that we're using in treating this disease. But avacopan is, at the same time, a fairly recent drug. So how is it possible to combine the features of the vasculitis of this AAV, which is, as I said before, something that develops over sometimes a very long period of time, with clinical trials and experimental data that have been collected over a short period of time. Are those data that we have, we've been able to collect, reliable? Sometimes when I think about that, I think about the famous paradox of Bertrand Russell, when he claimed there is a problem in our knowledge based on empirical experience, on empirical evidence. Take, for instance, a turkey and a farmer. The turkey associates the farmer with food. The farmer brings food to the turkey to get him wealth and fat. And so this is the empirical association of the turkey with the farmer. The farmer is someone that is going to be positive for me, is bringing food. The truth is, the turkey is to be killed on the day of Christmas, said Bertrand Russell. So the true scope of the farmer bringing food to the turkey is to kill him once fed on a Christmas day. Of course, from the empirical evidence collected by the turkey, the farmer is positive, but in reality, the true scope is the killing of the turkey. So how do we know? Sometimes I use this thought to think about we are actually collecting short-term empirical data on avacopan, for instance, but how do we know if in 10, 15 years, over a long period of time, the result, the clinical data of avacopan will be the same? So this is the thought that I wanted to offer to the audience. Thank you.
Thank you, Marco. Gary?
Thank you. I just wanted to take the opportunity to reiterate the point that Alistair made regarding the importance of increasing awareness of and enrollment in clinical trials for patients in IgA nephropathy. I was going to start by saying something which may or may not be controversial, but which comes from a position of complete ignorance, so it's definitely dangerous. And that's that it strikes me from just hearing all of this today and from the reading that I've done around the disease that we're probably 5, maybe 10, maybe 15 years away from the point where we'll be able to halt or significantly slow progression of IgA nephropathy in a majority of patients, which is tremendously exciting. But unfortunately, where we are right now, from a patient's perspective, is that there are no approved therapies in the UK at least. But there is this very, very rich pipeline of drugs. And that rich pipeline of drugs is tremendously exciting if you're at a relatively early stage of your disease, or if you have relatively slow progression. But there's a rather large cohort of patients who are later on in their disease and who are progressing more rapidly, for whom they may not have the opportunity to try those drugs as approved therapies before they reach end-stage renal disease. And I think that there's just a huge amount more we could do to encourage those patients and increase awareness. I don't think most patients know that patients that go into clinical trials do better than patients who don't. And so I think there's probably an opportunity for us to be a bit bolder in our communications and our attempts to try and steer patients in that direction.
Thank you, Gary. Fabrizio?
I'll try to address question number 4, and I take the occasion to have so many pharmaceutical companies here. So how would you suggest improving clinical trial design and implementation in your disease? I'm speaking about C3G. First point is, since the onset of this disease is mainly in children, pediatric age, try to open the trials to adolescents. Let's say, for example, from 12 years old up. I know that someone already did it, that someone has the intention, but this can be very important because if we wait 18 years old, sometimes it's too late. Second point, try to simplify the taking of the drug or the treatment. Better at home, if possible, and not in the hospital. Better oral and not infusion, if possible, not too frequent. Third point, if you can place less people on placebo. So we have a little number of patients that the less people you put on placebo, the better it is. And fourth point, the possibility to continue the treatment if a trial is effective after the trial is finished without interrupting it. This is very important for patients participating in trials. Another point is to reduce the washout period. And the last one, to have treatments with affordable costs for patients, and so to avoid discrimination. That's all.
Thank you, Fabrizio. I'd like to now open this up to the audience so that you can ask questions of the panel.